Welcome everyone to our second annual William T. Branch Jr. Innovations in Primary Care Lectureship. I'm Shelly-Ann Fluker, and it's my pleasure to chair the committee that has organized our 2021 William T. Branch Jr. Innovations in Primary Care series. Our series was created to honor Dr. Branch, who is an innovator and pioneer in medical education of trainees and practitioners with a focus on primary care. Inspired by Dr. Branch, the purpose of our series is to offer innovative, interactive presentations that promote the lifelong learning of humanism in medicine, support the development of professional identity and a bond to the primary care profession, and foster collaborative collegial relationships among health professionals. We are delighted to have with us as this year's speaker, Dr. Dennis Novack, Professor of Medicine and Associate Dean of Medical Education at Drexel University College of Medicine, where he directs clinical skills teaching and assessment. For almost 30 years, he directed first-year medical student courses on medical interviewing, biopsychosocial aspects of care, self-awareness, and professionalism at both Brown and Drexel University Schools of Medicine. He is one of the founders and leaders of the Academy of Communication in Healthcare, is a past president of the American Psychosomatic Society, and is president-elect of the Academy of Professionalism in Healthcare. He's also a longtime colleague and friend of Dr. Branch. Dr. Novack's presentation is entitled Realizing Our Potential as Healers, Professional Identity Formation. After Dr. Novack's presentation, he will have a discussion with Dr. Linda Orkin-Lewin, Professor of Pediatrics and founding co-director of the Woodruff Health Educators Academy at Emory University School of Medicine. He has led educational programs across the educational continuum from early medical students through residency training, and now is focused on faculty development for educators from across the health sciences, with an emphasis on development of educational scholarship. Her own scholarship has focused on supporting future primary care physicians, assessing communication skills, developing interprofessional education programs, articulating competencies and milestones for professionalism, and professional identity formation. Please feel free to type questions in the Q&A or chat, and we will include as many of your questions in our discussion as possible. I will now turn things over to Dr. Novack.
Okay, great. Thank you. So let me just say before I share my screen that I'm honored to be here to do a lectureship in Bill's name. As Shelly-Ann said, I've known Bill for nigh on 40 years, and I know of his work. I've followed his work over the years, have taught with him, and I want to say that that Bill Branch is a national treasure. He's one of the great men of American medicine, and from the very beginning of his career, from the textbook, one of the first textbooks in general medicine, general internal medicine, back I think it was in the early 80s maybe, and went through 4 editions, and really groundbreaking work in communication in healthcare, in humanism in medicine, essays, theoretical papers, amazing research on faculty development in humanism, all in the service of creating humanistic, compassionate physicians. Has mentored many people, and I'm grateful to be his friend and colleague. So let me share my screen and we'll get started with this talk. Linda and Michelle, and I do want to thank Michelle for her sort of gentle guidance and Shelly-Ann for her gentle guidance and organizational abilities in putting this thing together. I'm trying to get rid of this, these pictures. But hold on. Well, so I'll just start with this picture. So, and first of all, I've got about a half hour, and then Linda and I are going to talk. So I'm going to take you through a lightning a tour of professionalism and professional identity formation. So a lot of where Bill and I have been and have gone is related to the work of this man. This is George Engel. I was a fellow of Dr. Engel's 1976 to 78, and was there when he published his landmark article on the biopsychosocial model. That paper, I looked today, that paper has been cited 16,625 times. So that article on the need for a new medical model, a new way of looking at health and illness through a biopsychosocial lens, a more scientific approach to care, really has influenced education and care throughout the from then until now. So for some reason, I'm not moving forward. So let's see how I can do this. Sorry. Let's see if this works. There we go. So the biopsychosocial model, I think you all know about it. It basically says that people are really influenced both from the subatomic particles, atoms, molecules, organelles, cells. We're constructed not only of that, but of the influences of our family, our community, our society, our past history, and so on. And George Engel's argument was that we can study all this and we can study the interactions. So that led to a number of questions. Primary among them is, what kind of doctors are we? Do we only treat disease? Are we just technicians? Or do we treat the whole person? Do we treat disease, or do we treat illness, which is the subjective sense of dis-ease? What the patient is feeling. We can cure disease with drugs or surgery, but we heal with our words, and that healing has sustained our healing professions through thousands of years when we really didn't have much to offer except for our words. And the biopsychosocial model has really, and psychosomatic medicine, psychophysiology, has extended our understanding of the interactions of mind and body, and the unity of mind and body. So the science has gotten much more robust, but there still is an art, and that art is how we use ourselves in the practice of our healing. So why professionalism? So the story of professional identity formation starts with professionalism, which has been a buzzword and a focus of medical education for about 25 years now. And there have been, I don't have to go through all of the influences. Here are some of them that have made leaders of medicine, in medicine and the healthcare professions, worried about professionalism. So many factors that are eroding trust in physicians, and making medical practice in the doctor-patient relationship more difficult in many respects. And then there was this statement by Tom Inouye, who wrote one of the foundational documents of the current efforts in professionalism when he was a scholar in residence for the Dell AMC. He wrote a white paper, Flag in the Wind. And he said, as they move through their undergraduate medical education experience, students also move from being open-minded to being fact-surfeited, from being intellectually curious to being increasingly focused on just that set of knowledge and skills that must be acquired to pass exams, from being open-hearted and empathetic to being emotionally well-defended, from idealistic to cynical about medicine, medical practice, and the life of medicine. And I don't know if any of that sounds true to you today, but it does to me. So there's lots of definitions of professionalism. I like Howard Brody's and Dave Ducas's definition. Professionalism is a trust-generating promise and a application of virtue to practice. They say, you know, it's simple, really, when you break it down to those two. But then again, lots of organizations, groups have put out their own definitions of professionalism. One that has been cited and supported by hundreds of medical organizations around the world is the Professionalism Charter that came out in 2002 from the American Board of Internal Medicine. A number of ACP, ASIM, the Society of Internal Medicine, the European Federation of Internal Medicine, leaders in those groups put together a charter that consists of principles and commitments. So the principles are primacy of patient welfare, patient autonomy, and social justice, interestingly, which some physicians would have disagreed with in the past, but that's become more of the identity of physicians. The notion that physicians, really all healthcare workers, have a say and can influence that arc of justice. Commitments, so it consists of principles and commitments, and you see the commitments and you'll recognize them. And if you look at a number of the definitions in professionalism, the American, the AAMC has their own definition. There's a number that look pretty much like this, though. There's a lot of overlap. So, you know, professionalism really started being taught in earnest only in the last 10 or 15 years, I would have to say. And one of the articles, one of the studies that sort of spurred that was by Maxine Papadakis in 2005. And actually, we had Maxine come to a visiting scholar day with us shortly after she published this study that showed that physicians who were disciplined by their state boards had a 3 times, compared to a control group, were 3 times as likely to have had professionalism citations in medical school. And, you know, I walked out of her talk in 2005 with our curricular dean, and I said, you know, we're pretty good at dinging people who are unprofessional, our students, and working with them, but we haven't done much to teach professionalism. And that's when we started really thinking about how we might do that. And I started thinking about, can you do that? You know, because I actually was one of those people before all this who thought, no, professionalism, how do you teach that if people haven't come into medical school with honesty, integrity, compassion, if they haven't learned all that at their parents' knees, you know, how are we going to teach that? And I think I started understanding from the work of Tom Inouye and Rabo and others that, well, you know, actually, we can teach professionalism. That is, we can articulate what are the goals and commitments and principles of professionalism and have people commit to them. You know, the white coat speech, the oath of Hippocrates. We have people take oaths, write their own oaths. So you can commit people to it, but can you move them forward? You know, a lot of people started writing about how you might actually do that. And the vehicle is professional identity formation. So yes, the work that Bill and I did in the Academy on Communication in Healthcare always had a focus on identity formation, on how do we get better at being a physician, being a teacher. So, so there have been important documents along the way. One of them was about 10 years ago when the Carnegie Foundation, who supported the Flexner report 100 years earlier, decided to, let's relook at the Flexner report and see what really needs to be done now for medical education. And Molly Cook and David Irby and Bridget O'Brien in this text made identity formation, professional identity formation, one of the 4 main goals of medical education. And they say development of professional values, actions, aspirations should be a major focus of medical education. It should build on essential foundation of clinical competence, communication, interpersonal skills, ethical and legal understanding, and extend to aspirational goals in performance of excellence, accountability, humanism, and altruism. So there are a number of definitions of professional identity formation. There's a couple I like. One is by Mark Holden and colleagues from University of Texas, Galveston. And, they say professional identity formation is the transformative journey through which one integrates the knowledge, skills, values, and behaviors of a competent humanistic physician with one's own unique identity and core values. This continuous process fosters personal and professional growth through mentorship, self-reflection, and experiences that affirm the best practices, traditions, and ethics of the medical profession. So I think that's a pretty good definition. The Cruces, Sylvia and Dick Cruz, the grand old couple of professional identity formation. I was just at a conference when Sylvia presented, and we all sang happy birthday to her. She turned 90. That was 2 years ago. She's still going strong. The Cruces, basically say that professional identity formation is in large part a socialization phenomenon. And they recommended adding another pinnacle to Miller's pyramid, which I think you know about this, so and how you assess physician competence. So knowledge knows how, shows how, performance does, do they do it in practice? But then the highest level is consistently demonstrates the attitudes, values, and behaviors expected of one who has come to think, act, and feel like a physician. In other words, they are physicians. We just don't do medicine. We are physicians. So, what are the elements of professional formation? I think some of them are embrace a biopsychosocial perspective, because that's the most holistic way of understanding health and illness. Reflect on and develop core values and develop congruence in thought and behaviors with your core values. You need to enhance your communication skills, and you need to work on self-awareness and use that awareness in enhancing your relationship with patients and colleagues. And about 25 years ago now, my colleagues and I from the Academy published an article on personal awareness and effective patient care. We were lucky enough to get that in JAMA. And we published a curriculum essentially in personal awareness. And that was based on the work that we had done, that Bill and I and a number of others, some of whom I think may be at this lecture now, had done in our faculty development courses. We put on faculty development courses for starting in 1982, 83. There's like, we're now on our 35th or 36th, I don't know. But, and Bill and I taught in many of them. I think I taught in about 20 of those courses. And in all of those courses, we emphasized, we had specific groups, small groups that where we examined our personal awareness. And we learned a lot about how to do that and how to create exercises and all that would help us understand our own personal awareness. And I think you can't just talk about personal awareness and reflective practice without talking about some of the basics. So, one of the basics is that notion of what is in your listening, because healing requires open, generous, non-judgmental listening to patients. And if you think about, I did some courses with Landmark Education. They do, it's a transformational education program, and they have a lot of nice concepts. And one of them is, what's in the clearing of your listening? What are you listening for? What is in your listening is often judgments, assumptions, needing to be right, your own emotional triggers getting your buttons getting pushed, you take things personally. All that clouds your ability to really listen. If you can get rid of that or step aside from all of that and have a clearing, then patients can pour themselves into it and trust you. So, I wanted to put together goals and objectives for professional formation, because I think the basis for professional formation is personal growth. And there's a lot of people who know something about personal growth and how to promote that. And if you have overall goals, if you have goals and objectives, you're much more likely to know if you've gotten there, at the end of the journey, if there ever is an end. So overall goals, students should be aware of how their personal histories, cultures, personal lives, values, attitudes, biases affect the care of patient, and should be able to use that awareness and emotional responses in patient care for their patient's benefit. And students should care for themselves physically and emotionally, because if you don't have well-being, you're not going to be very helpful to patients. So I'll come back to that. So what are the objectives? So I'm going to go through these rather quickly because I need to finish up in about 8 minutes, but hopefully there'll be time to talk about some of this. So students, the objectives, students must learn to, in order to grow personally, explain the virtues that guide their interactions with patients and colleagues, providing concrete examples. We all have values, virtues that we mainly talked about over beers at 2 a.m. in college, but how many of us really think about what are our core values now, and whether or not our behavior with patients and colleagues really reflects the values that we hold dear. And there are ways of actually measuring that. Discuss their own character strengths and limitations, emotional triggers, attitudes, and ways of thinking, how those affect relationships with patients, clients, and colleagues. You can take all these, you can take tests on your own character strengths, and they're online, and some of those are really quite revealing and interesting to do. Navigate the balance between objectifying and over-identifying with patients and clients. Medical students start this from the very beginning of their medical education, when they dissect a cadaver and have to objectify the human body and separate it from the spirit. And then, in clinical years, there's that danger of over-identifying. You love certain patients, you want to go the extra mile, and you can get in trouble if you cross some boundaries. So, how do you navigate that? How do you get appropriate levels of empathy and caring without overstepping your boundaries? Confront your fears of death and become comfortable giving bad news and talking with dying patients and their families. I had a lot of trouble with this when I was a young physician. I felt vulnerable, afraid of mortality. People were dying on my service. I didn't know how to talk to patients. Back then, there was no education, nothing on how to work with dying patients, and I had to navigate my own way through it. Now, thank God, there's lots known about how to do that and how to face your own fears of vulnerability and death. Move from self-centeredness to patient-centeredness. This is a big one. When you think about students who, high school students, college students, they're competitive, they're self-centered. They have to be in a lot of ways, and then they get into medical school, and suddenly they have to become patient-centered, put the patient's interests above their own. And there's data. We've done a study on this as well that show that students by third year, still the majority of students would subvert patients' interests to their own when educational issues come up, or when asked to do something that they don't think is quite right, but the attending asks them, so I better, cultivate your commitment to social justice and thought and action. There are a lot of aspects to this. Just allocation of finite resources, the vast inequities in our healthcare system, anti-racism. I'm one who believes that we, as healthcare providers of all disciplines, need to get on board with health equity, with doing something about it, and with being upstanders and anti-racists. Become confident in what you know and what you don't know, and admit when you don't know and ask for help. That's not that easy, actually. And I, in my younger days as an attending, I would get in trouble sometimes when I didn't know. I delay. I try to figure it out myself. I didn't want to admit I didn't know. But when a patient gets hurt, it makes you stop and think, I better just always admit I don't know, and ask for a consult. That's what consults are for. Learn from mistakes through reflection and discussion with others. There's research that shows if you project and blame others for your mistake, you don't learn, you don't get better. You have to thoroughly examine your own mistakes. Become helpful members and leaders of team. When Bill and I and some of the folks in this audience were young, we were heroes. We were the Lone Rangers. We were the leaders. It's not in the best interest of patients. And good care, best care, effective care is team care. And sometimes we're leaders, and sometimes we're followers, and sometimes we're collaborators, and we got to get used to all that. Grow in moral development. You can actually think about your own moral development and where you are. And we can talk about it later if people are interested. Linda, I know, knows a lot about this, having worked with Bob Keegan. Enhance your capacity for empathy and compassion and skills in communicating those. Some people think that a capacity for empathy is like talent in playing the piano. You can sit down, no matter how many lessons you have. If you don't have natural talent, you might not be so good at it. And there is something to that. There's some neurobiology of empathy, but you can teach people to express their natural empathy, and you can. It may be that you can create some new neural pathways. A little bit of neuroplasticity by teaching people empathic expressions. And those studies need to be done, but I think they're coming. Develop emotional intelligence and emotional regulation. This is something that is a lifelong endeavor. I'm still working on that. People who love you the most can push your buttons the easiest. Sometimes, in recent years, I've gotten much better at this, I think. Well, my wife is sitting in this room. Maybe she could tell me, but, sometimes if my wife pushes my button, instead of reacting, I just think, okay, so how do I want to spend the next few hours of my time before, I eventually apologize, and, I don't necessarily react. So emotional intelligence, emotional regulation is something we can teach and we can learn and we can get better at. Balance self-criticism with self-acceptance and gratitude. Physicians especially tend to be very self-critical and have negativity bias. if you get into positivity and gratitude, do 3 good things every night, like Marty Seligman suggested, write down 3 good things that happened to you. You start there, Seligman actually did a study that looked at 6 months later, people who wrote 3 good things down every night, even for just 1 week. And on a validated happiness scale, people were happier than the control group 6 months later. Develop moral courage. You can help people find their voices. You can help students find their voices and speak up, be upstanders, and be contributors to a positive learning environment. Because if they don't say something when an attending or a senior resident says something inappropriate, they have contributed in a negative way by not saying anything to undermining the learning environment. Then finally, again, maintaining your well-being so you can be present for patients, clients, and colleagues. If you're listening to a patient pour out their hearts and thinking, whoa, you think you have trouble, you're just not going to be effective. So, we're trying to help people become mature, to develop mature defenses like humor, identification, sublimation, emotional self-sufficiency and regulation, and so on. What can faculty learn, role model, teach? So you can see that all of these topics are teachable, and there are courses that teach the skills of these topics. You can role model respect for patients. We can reflect on our core values, create an environment of acknowledgement and gratitude and appreciative inquiry. We can model virtues, the Aristotelian virtues of respect, moderation, patience, courage, forgiveness, acceptance, and so on. And what can we do? We can become the change we want to see. We can work on our own well-being, improve our own self-awareness, comment on professionalism breaches, model empathy, and comment on what we're doing while we're doing it. On rounds, model effective interprofessional relationships. And I just want to say that we have a resource online, professionalformation.org. This is you can see at the bottom a link. It's right now. It's all the modules are freely available. There's 14 modules online. We were supported by Arthur Vining Davis and the Macy Foundation to create this. It's an interprofessional resource, and it will. We have to charge subscription fees starting next July because it's very expensive to keep this thing on the web and to keep it updated. But it'll be very modest, and partly we are supporting the Academy on professionalism in healthcare, which is a great society. We've got about 140, close to 200 members, I think now, of scholars and teachers throughout the country of professionalism, ethics, and so on. So let me stop there. So thank you very much. I think I went over a couple minutes, but let's begin the discussion.
Great. Thank you so much, Dr. Novack. That was indeed a lightning tour, as you said it would be. So now the question is, with the next 20 minutes, how much of that we can talk about in a little more detail. So my mind always goes to the places of conflict. And you said that one of the main objectives of professional formation, or the overall goals, is for students to care for themselves physically and emotionally, which is absolutely true. But a couple slides later, you said that one of the big goals was patient-centeredness rather than self-centeredness. And while you and I probably, after some years of practice, know what we mean by that, I feel like that's a place that our learners kind of get stuck, and it's a little dicey. So I wonder how you address that with students and other kinds of trainees who are so early in their kind of training.
Yeah, you have to kind of call them out on it with effective educational immersive programs. So, for instance, we have we have a ethics OSCE. So one of the cases we do that we studied, and I referred to it earlier, is the door instructions say you saw Mrs. Smith last night with the team who said she didn't want any medical students involved in her surgery, although they could watch. And you're about to go in and meet the head of surgery, who is going to be performing the operation. So you walk in, and there's a standardized patient in scrubs, venerable guy in his white hair in his 60s, and he goes, "Hey, guess what? You're going to get to intubate today, and this is a great opportunity for you." So then the students go, "Oh yeah, but Mrs. Smith said yesterday that she didn't want it." And he said, "Oh, she's sedated already. She'll never know. And she signed a permission slip when she first got into the hospital that said there are medical students here. It's fine. We've done this many times. Don't worry about it." And then the student objects a little bit more, and he says, he said, "You could save somebody's life if you know how to do this well, and we're going to teach you." And then the student says a little bit more, "I don't know, I really don't feel that comfortable." And then the attending says, how the heck am I going to evaluate you if I don't see you at work? It keeps upping the ante. And finally, after 15 minutes, 90% of the students say, "I just don't feel comfortable with this. I'll do it another time. Thank you." Right. And then, we created a questionnaire based on the theory of interpersonal behavior. It's a whole big thing. But we asked them, if this were the real situation, what would you do? 55% of 265 students said they would intubate. And the ones who said they would intubate were more likely to think that, well, the other students will do it. It's commonly done, and I trust the attending, that I trust authority. The ones who said they would refuse in the real situation, endorsed a number of the commitments and principles of the professionalism charter. So, our interpretation was, well, those 55% match up pretty well with what Keegan thinks is, stage 3 of the population, that care more for what other people think, the socialization and authority than for the patient, So we have students to, go through this, and we talk about what they put down on their questionnaires, anonymously, obviously, and we talk about what's right, and how do you get the courage to stand up for what's right, and what do you do when you have an attending who's telling you to do something that's not right? What are the reporting? Because if somebody's being abusive, they're going to abuse other students. So you have a responsibility to your fellow students. So we have a very rich discussion about that, and I think we do change some minds and behaviors. Who knows? We have to study whether we actually do.
Well, it's interesting because, as you know, if you look at development along Keegan's model, which I'm not going to go into in any great detail, but it is true that the majority of adults, and certainly young adults, their job is to live up to the expectations of important people and groups to them, right? And so if you are the attending and you are the venerable doctor, and you represent the whole profession of surgery, it's kind of their job to please you so that you will accept them. And at least in my understanding, each of these little dilemmas, a disorienting dilemma as it would be called, kind of tweaks people into wondering what they should do, right? And then the debriefing that you're doing is fabulous because it allows them to sort of objectify it a little bit more and potentially get a little bit broader view. I would be shocked, though, if many people changed their whole way of viewing these things, based on one or two interactions, according to Keegan. And I think in real life, we all remember that it's sort of a process. So you have a series of things that you kind of come in contact with and have to reflect on until someday you finally think, oh my gosh, this is all different than what I thought. And so,
Yeah.
yeah.
Well, I have two comments. Yeah, I love what you said. And I have two comments in response to that. One is that's why Bill's work has been so important, because if you can do faculty development, change the learning environment, get the faculty to be more responsible, maybe they have a better chance at being at Keene level 4, let alone, God knows, 5, but if they endorse professionalism and professional behavior and empathy and compassion, you're going to change your trainees a lot more quickly. And I think, people do change. I'll tell you a personal story. When I was a third-year student, my first rotation was on surgery, and it was 1970, I guess. And I had long hair. I had hair down to my shoulders, right? I was in the Vietnam War. I was a protester. I was a hippie. And I walked into the surgical suite, and so one of my fellow students said, "Oh, you got to put on this, headdress, this sort of Alibaba headdress that covers everything." And I looked in, and I won't say his name, but the head of surgery, I looked into his surgical suite, and he had hair showing underneath his cap. And I'm like, well, if it's good enough for Dr. W, it's good enough for me. And so I just put on a cap with my hair flowing around it. And I went in, and 5 minutes later, I was retracting, and the chief nurse came by, and she looked, and she did a double take, and she started, mimicking, miming, stamping her feet, put on that headdress. No, I just smiled at her and shook my head. I'm not going to do that. And she finally gave up. The next day, the clerkship director called me in and said, Chief of Surgery is so angry with you that he wants to throw you out a window. And if you don't go apologize to the head nurse, the chief nurse, and change your ways, you're failing this rotation. And it's like, oh, great, my whole life, is gone. So I went in with a certain amount of righteousness to her office and said, look, Dr. W had hair showing under his cap, and if it's good enough, and she said, stop. Suppose a hair fell into the wound and caused an abscess, and that patient was your mother. And I said, oh, you're right. I'm sorry. Yeah, I get it. And, in that one moment, I suddenly gave up being self-centered and worried about how stupid or not I looked and started thinking, no, what am I in this for? It's for the patient, So I think if you can create powerful enough experiences, you can change people pretty quickly, at least in my own experience. Sorry.
No problem. Leanne, is there anything in the chat that we should address right now, or?
There was a comment from Carrie who mentioned that she was teaching some third-year Emory students about the ethics of speaking up in the similar circumstances to what you all have been describing, and that they would be uncomfortable because they worry about grades and letters of recommendations. And then she also went on to say they also felt like doing some of the things they view as unethical now will seem more normal and acceptable, and they are themselves in the position of being the attending. So she was just making a comment.
Yeah, students are resistant to speaking up, but I think you can get people to role play. You don't have to speak up in an obnoxious way. You can ask a question that kind of interrupts or the flow of the negativity or the inappropriate comments. We're doing a module now on another module for PFO that will be freely available on anti-racism, and we're going to have some videos on microaggression, speaking up in the moment in a helpful way. You don't have to get angry. People think, oh, I have to, by speaking up, I'm going to be, obnoxious and angry. and the world will come crashing around me and my grades will be affected. But I've seen instances where students have spoken up and changed the whole tenor of the discussion in the team. And I think students can be taught how to do that, and they can be taught how to do it later. You don't have to do it right in the moment. You can seek out the resident or attending later and say, you know, gee, I was kind of uncomfortable with that comment you made. Can you explain it a little bit more to me? Or if that doesn't work, go to the clerkship director, you know, because you don't want to be part of continuing a toxic learning environment. And I think students can speak up. They have a voice. They can realize they have a voice, and they can speak up appropriately.
Well, I see that Carrie noted that students feel like they're kind of powerless to change the culture. And I think it speaks to the need for a several-pronged approach. So we definitely need to do standardized patient experiences and role plays and things like that to prepare students and give them some words. And we definitely need to do some debriefing where they have a chance to talk about things that they've seen in the learning environment that have distressed them in some way. But I think where we have so much trouble is actually reaching the people who create the culture, right? So our students and trainees are exposed to a huge number of individuals as they travel through their training, and those people don't always recognize what role they play in the formation of the identities of these learners. Yeah. And I think faculty development is really, really important, and it's really good for all the folks that you guys have trained over all the years, but it's almost more important for everybody else. And I wonder if you have thoughts about how you can kind of let those things trickle down to the rest of the faculty, not just, you know, the people who come to your courses and trainings.
Yeah, well, it takes leadership. You know, I mean, the chairs have to be on board with this, and create some faculty development opportunities and model what they want in professionalism and in creating good, effective learning environments. You know, I attended on inpatient medical wards for many, many years. Nobody ever taught me how to teach or how to create a learning environment that allowed people to speak up, you know, and feel comfortable and allow, you know, where feedback and appreciation and gratitude and acknowledgement were current and promoted learning. But, you know, I think people would be, I think we all want to be better at what we do. And if we create effective programs, I think that in faculty development, I think that will help. I think the other thing is students have to trust the feedback system. So I'm on the professionalism review advisory board of our school. And I see, you know, I've seen a lot of issues raised by students in our confidential reporting system about specific attendings. And our system is good. I mean, our student deans make sure that the person who was abusive or inappropriate does not have anything to do with that student's grade. They get personal feedback from their chair after the student has completed the rotation, and they aren't told who gave that feedback, but the chair will have a discussion with them, you know, that kind of cup of coffee conversation. And you know, if that behavior continues, there are consequences. But the students have to trust it, and I have to say the students don't completely trust it, even though we tell them and we give them little talks and reminders, but they're still scared, you know. So there's a lot to be done.
Dennis and Linda, I wanted to combine a couple of questions that came in, and also folks want to hear from Dr. Branch as well, so we want to make sure we leave some time for him. But Dr. Wolf asked a question about the importance of getting and giving feedback. And then Dr. Frankel asked about remediation for professional lapses and its relationship to professional identity formation. So I wondered if we could maybe lump those two together. Specifically, Dr. Frankel wants to know, what are the limits of remediation efforts and where do we say enough is enough, and close off the opportunity for students to demonstrate unprofessional behavior to progress. So maybe lumping that together with Dr. Wolf's question about giving feedback.
I'm sure Dr. Novack knows the answer to that question, right?
I can say something about it. Well, feedback's a whole nother topic, and there's lots of great articles going back to Jack Endy on the nature of feedback and how it's most effectively given, and a culture of feedback. Feedback should be given frequently, but also mid-rotation. Every student should have some feedback mid-rotation and find out how they're doing, what they can do better. I would say, so Rich Frankel, who is another great man of American medicine, he's another colleague. He's a plant in the audience, I guess. Thanks, Rich, for being here. Great. A great contributor to doctor-patient communication studies. So, and Rich knows some answers to this too, because he's been very much into remediation. I'll say that, on the professionalism review board, we have we have 1,000 students. We have 265 students in each class. So, do the math. And we probably have 14 or 15 students who are getting remediated at any one time for professionalism lapses. There's no one template. I mean, we do have a template that says, what the lapses are. We create a contract. We meet with each person, and we create a contract. They get a mentor on our committee. And they agree on what they need to do. And it involves readings, it'll involve changes in behavior, et cetera. And we hold people to those contracts, and we meet with them fairly regularly. I will, so in response to the last part of Rich Frankel's question, when do you say enough is enough? I'm dealing right now. So today, I sent an email about someone who failed our CSA, our clinical skills exam, but is also, I know him because he's one of the people under remediation for professionalism lapses, and his lapse is consistent unreliability. He doesn't answer emails. He doesn't show up. After 2 emails that said, okay, you're going to meet with Dr. Peitzman to go over your physical exam. It'll be at our facility with a standardized patient. He didn't show up. This was 2 days ago. We called him. He said, oh, I thought it was online. No, you got 2 emails. So what's going to happen to him? Everybody loves this guy. He's a nice guy. And he passed, in fact, did reasonably well in all his rotations. So yeah, he's going to get an MD degree. But he's going to get in his letter that goes out to all residency programs, he's going to get a very stern paragraph about his professionalism lapses and how he's unreliable and doesn't show up. You think he's going to get a residency program? What he's going to get is an opportunity to do research at some lab, and then maybe, over some years, he might rehabilitate himself and try to get a residency again. But that's what's going to happen to this guy. So, yeah.
So Shelley Ann, is it time?
We have 1 minute before I wanted to pass it off to Dr. Branch. If you have a comment, Linda. Just everything he said. Yes, in 1 minute, I can answer that question. I think there's a lot that can be remediated if you give students a chance to really sit down and think through the things that they didn't realize were unprofessional. But there are certain students and people who just
don't or can't. And I'm not always sure I know the line between remediable and actually needing some evaluation for a deeper problem. And that can be really challenging. But there are a lot of students who look surprised when you explain to them how it looked to you. And they never thought of that.
Yeah,
Oh,
self-awareness is
Branch.
not one of the strong points. Yeah.
Okay.
All right, well, thank you so much, Linda and Dennis, for that really rich conversation. We're gonna let Dr. Branch finish us up with his comments, and then I'll close us out with just some thank yous. Bill, you can go ahead and unmute.
Oh, you're still muted, Bill.
There we go.
There you
I
go.
think I just unmuted. There's so many of you I need to thank that it's going to take all of my time just to do that, probably. I am eternally grateful to all of you, especially to Dennis, a very old and valued friend who came here and gave us a tremendous overview of what's been going on really for the past 40 years. I also want to thank Shelley Ann for organizing this, Linda Lewin for being the moderator, and probably there are dozens of other people I need to thank, and I will reach out to them. So I'm certainly learning. I'm learning all the time. I think I take a step backwards and maybe a step and a half forwards frequently. At the moment, I'm internalizing as strongly as possible the virtue of gratitude and humility. Humility is a big virtue. I just would say that over the 40 years that I've been involved in teaching basically professional development, I think there have been a lot of big changes. And I think that it happens gradually and we don't see it so easily. And if you, however, compare the way things were and what people were like, what the hidden curriculum was like up on the wards 40 years ago with what it's like today, the difference is big. And the students and residents, they're more mature. They're able to relate much better to patients, and they're not so cynical as what we saw years ago. And this has been a gradual process. The other point I would make is it takes a village. I know that one of the things I feel just warms my heart is the folks here at Grady, the faculty in general medicine, who I worked with over the past 26 years. And I mean, this is a group which we gathered here, and they have been just amazing in terms of how they have taught, taken care of patients, and transformed, I think, the learning climate and the patient care climate. And to some extent, we have a long way to go with the social justice climate as well. And this took a village. This was not me, but it was me cheering on a number of people, a great number of people, immensely talented people. So also I could acknowledge some of my mentors and guides. I saw a comment by Marshall Wolf, who was my mentor. He loves to say I was his mentor. The joke. But Marshall was kind of an ideal person for me to model myself after in many ways. Rich Frankel has worked with me for quite a number of years, and the two of us together, I think, have done some good work. So I'm not going to continue to try to find everybody that I owe something to. But I think for everything I've given, I've gotten back about two or three things from other people, and I'm very grateful and very humble.
All right, thank you so much for those comments, Dr. Branch, and thank you for being one of my mentors, and thank you for being the inspiration for this series, which I think has truly been a blessing in the last 2 years to us, and I look forward to having many more discussions like this. I just want to end by acknowledging my committee, who I could not have done this without, them. They're listed here. They're faculty from across the Emory healthcare system. And I also want to acknowledge my administrative partners, LaQuanda Jackson, Leigh Partington, and Katie Playa, who helped us to put this event on. So thank you all again. Thank you, Dr. Branch. Thank you, Dr. Novack, Dr. Lewin. Thank you for all of you who have attended. And I hope we will continue to have these conversations, because I really think they're critical for ourselves and for our trainees. Have a good night, everybody.
Thank you. Take care.